So let's talk about COVID-19 in our country. And we know that doctors have felt the heat and the brunt. And yesterday, doctors called a press conference in which they were discussing COVID-19 because of what has happened to many of their colleagues. Number of them have passed on, and now doctors have said, look, you know what, enough is enough. It's suicidal, doctors said, as they gave a strike notice. Yesterday, they gave a 21-day strike notice saying, look, we need this matter addressed because many of our doctors are dying, and this is just from not just from the doctors, the Kenya Medical Practitioners, Pharmacists and Dentists Union, but also the Kenya Union of Clinical Officers has also joined in that call because of the number of doctors that have died in the last couple of days. These are many doctors, many of them, and we know, obviously, from the very beginning, we said doctors and medical workers are our frontline fighters in the war against COVID-19. Many of them are now saying, look, we are exposed. We don't have access to PPEs. We don't have even access to, we don't even have medical insurance. This is a conversation that was had a long time ago. In fact, the president said, you know what, medical insurance is something that is going to be provided to the healthcare workers because they are our frontline workers and frontline soldiers in this fight. Now they're saying we don't have that. As we saw the press conference that was addressed by the leadership of the KMPDU yesterday, Dr. Chibanzi Mochonda, who's the Secretary General, came out and said a number of these doctors who've passed on, many of our members and their families have had to contribute to foot the bills, the hospital bills for these members, because some of them had bills running up to millions of shillings, 2 million shillings and thereabouts. And there's no help forthcoming from the government. Just last week, the minister, the CS for Health, said NHIF cannot manage to foot more of these bills, so you are again on your own. These are issues that have been talked about for a long time. You know, how are we treating our healthcare workers? How are we treating our frontline workers? How are we equipping our hospitals? Are our hospitals able to address this issue? And it has just not moved anywhere. So doctors are saying in the next 21 days, if you don't meet our demands, which are very basic, provide PPEs, ensure that we have access to medical insurance and others. If you don't do that, 21 days, we down our tools. Enough is enough.
You know, the discussion of the PPEs, I have to ask this question, given the sort of mess we've been reading about at KEMSA. Do the PPEs meet the international standards that are required for such?
Which PPEs?
The ones we have in this country.
The ones being distributed to the doctors?
Yes, do they? Because if they are found to be substandard or faulty, they could also contribute to the rate of infections. Yes.
So they're not offering the protection that they require.
Yes. So I'm asking, do we have a standardized way in which we look at this thing? Can we be told categorically that these PPEs that we've now brought in the country and which are being used by healthcare workers meet the standards that are recognized internationally? Can that be said equivocally? Can it be said? Can it be stated? Can we get an affirmation?
Big question. Big question. We're going to be asking. Let's bring in our doctors because we have to have this conversation with them. Professor Lukoye Atwoli is the Dean at the Aga Khan University Medical College, East Africa. And also we have Dr. Allan Ochanji. He is the Vice Chairperson of the KMPDU, the Kenya Medical Practitioners, Pharmacists and Dentists Union. They're joining us on the line. Prof and Doc, good morning.
Good morning.
Thank you very much for joining us this morning, and we appreciate that you have had some time to join us. We know that Professor Lukoye Atwoli will be talking to you for half an hour as we continue the conversation with Dr. Allan Ochanji. So let's just begin with you, Prof. You've heard the question that CT is asking, and these are questions that have even been asked before, in terms of the kind of quality that we have of the PPEs being distributed in our healthcare, in our hospitals across the country.
Yeah, I think if you look at what we had starting in March, April, there was a wide variety of PPEs being purchased and distributed at extremely high cost. And at that point, many of the pieces of PPE that were being distributed were found to be of very, very poor quality. So at some point, there's a team from KMA, the union, and the Ministry of Health, together with people from KEBS, that started, reviewing the kinds of PPE that were being distributed and I think the quality improved significantly. So today, there is availability of high-quality PPE on the market. Now, those who look for those high-quality PPE are able to get them and purchase them and distribute to their staff. The tragedy is that in many public health facilities, that procurement of this PPE is not up to scratch. So you have a situation where people are being given a limited quantity of protective equipment, which they can only use for a limited period of time. And after some time, there are shortages, and what is being given is inadequate. And this is therefore exposing many of these health workers in the public health facilities to potential infection at their place of work and elsewhere. So this is a big problem. The fact that they are not getting adequate amounts of PPE is now the big problem, rather than necessarily the quality of those PPEs.
It's a problem, and it seems to be teetering on the baffling that it should be a problem that we are dealing with now. If we are saying that we're in the middle of a war against COVID-19, and you know that your soldiers essentially are frontline workers, and they need to be protected, and still unable then to care for the frontline workers to be able to get this done. Because if I present myself to hospital, I'm hoping that it will be a doctor, medical practitioner who is taking care of me, and they don't have this, then can't we then say that we are actually doing what needs to be done against this fight? I mean, where are we? What are we really doing?
Yeah, I think for a long time, and we have said this, countless times, this country has not taken the health of the citizens seriously. We have not bothered to put in place sufficient infrastructure. We haven't done enough to ensure that the facilities that we have are properly staffed with qualified human resource. We haven't invested much in human resource development among those that we have recruited. We haven't invested enough in research so that we have solutions that are locally generated that would then be able to, we can use them to address issues, including the pandemic that is upon us. We haven't cared enough about the welfare of our health workers to ensure that they are healthy and they are happy in order that they then take care of our citizens in the prescribed way. So we haven't taken this as seriously as we should. And the reality of this pandemic is that it has not presented a new problem to the health systems. The health systems are supposed to be built to deal with crises such as this pandemic. Health workers are trained to deal with crises such as this pandemic. What they do on a day-to-day basis outside of the pandemic is really preparatory work. So a good health system, a well-established health system, should not be shocked when a crisis like this pandemic comes in. They would just put in place the mechanisms that they have already, had in place, and they would deal with whatever comes. When you see a system collapsing, such as our health system, then what it tells you is that we were not prepared to deal with anything that a health system is supposed to be prepared to deal with. If you look at the health care workers' welfare, if you look at the health benefits that they are supposed to enjoy, in many public health facilities, an NHIF cover was set up, which looked good, and people could access health services covered by NHIF. Now, when you say that during a pandemic this cover is not available, this suggests then that the health cover was not adequate in the first place, because a health worker who gets infected outside of the pandemic, if he gets malaria, which is severe, he might need the same critical care services as a person who has COVID would need. So if you could cover critical care for somebody, a health worker with malaria, it beats reason why you wouldn't be able to cover them when they have COVID-19. So those are the things that tell us that our health system hasn't been set up in a way that is optimal, both to ensure that the health workers are ready to deal with the problems that they encounter and to help the public so that they can be confident that whatever comes their way, they can go to a health facility and get help.
So what we are saying, Professor Lukoye, and also for you, Dr. Ochanji, is that the problem then is not COVID-19. When we're looking at these, what we're hearing today, that somebody goes from one place looking for oxygen cannot get, it could be COVID today, Ebola tomorrow, a resurgence of HIV the next month. So the problem is not these diseases that we are facing.
No. The problem is not COVID-19. The problem is how the health system is set up. If people who are dying, if somebody had a mass accident in Matungu and required critical care and was taken to the nearest health facility, chances are that they will not survive. Because they will do exactly the same dance of moving from facility to facility looking for oxygen.
Yep.
If somebody got meningitis and required critical care somewhere in rural Kitui, the chances of survival are very low. So, but if we set up the system so that people requiring critical care can get it wherever they are and survive, then it doesn't matter whether they are requiring critical care because of COVID or because of malaria or because of a road traffic crash. They would get the care that they need because the system would be set up. And I'll give you an example. Even if you go to Europe and look at countries that were overwhelmed, and there are many examples, and then look at countries that were not necessarily overwhelmed, like, I take an example of Germany, although, of course, fingers crossed, you never know how this pandemic evolves. But what you will notice is that Germany had infrastructure in place to take care of patients requiring critical care. So it didn't matter whether it is COVID, whether it is anything that was coming their way, and they were able to take care of all the patients requiring critical care. At some point, they were even importing patients from other countries to help with the effort across Europe. If you come then to other countries getting overwhelmed, including the U.S., the U.S. health system was very fragmented, was very expensive, it was difficult for people to access care even before COVID-19. So when COVID-19 comes along, the system is very quickly overwhelmed because it is not set up to provide critical care services to a large population needing it. So it is about the health system setup rather than using COVID-19 to say, it's COVID-19 that is causing a problem. No, COVID-19 is causing a problem because the health system was not optimally set up to do exactly what health systems are set up to do.
Let me just ask this question. When you talk about a health system that actually functions, is it something that is feasible? On this continent, tell me, which country would you say has an effective health system?
So, question of feasibility is like asking, it's a good question, but it's like asking me, is it feasible to keep people alive in a country? That's the only reason governments exist. That's the only reason we come together, pool our funds, and elect people so that they can ensure that we are kept alive. So being kept alive, that we are healthy, and that we can be productive subsequently. So the question of feasibility doesn't arise. It is the raison d'etre for every government. Why we elect governments is to ensure we are alive, we are healthy, and we can be productive. And so any government that sits down and applies its energies and imagination on the problem of ensuring that people are safe and healthy will find a solution that will ensure that people are safe and healthy. But a government that says that this is not a priority, then we'll come back and ask questions about feasibility. How much does a human life cost? What is the value of a human life? That is a decision that is made, and then based on that decision, you invest adequately in the health of those people that you're taking care of.
That was actually the first part of my question. The second part is, you see, we are dealing with the preventative aspects of medical care. Now, when you are in a situation like the one we are in Kenya, where it is clear that the government we have or the governments we've had do not seem to be overly concerned about the very things you've been mentioning, what then can you, as a health practitioner, advise the citizenry to do in order to prevent? Because seeking treatment is the cost and the bother. If you could avoid it, you'd be much better off. What then do you do beyond the obvious?
So what I would advise Kenyans is that they must make a link between the political decisions they make and the health that they enjoy. That if you make certain political decisions, then your health will be at risk. And if you make a different type of political decision, chances of your health being better are higher. In other words, during political campaigns, during constitutional discussions and so on, citizens must interrogate what is on offer as far as health is concerned. Now, if citizens don't do that, the health workers do not have much. The health workers will work with what they're given. If you're given, a facility without equipment, you do the best you can, and where you can't, it will be obvious because there'll be higher mortality, people will suffer, and so on. But where you are given adequate tools to work with, then you will do a stellar job because that's what you're prepared to do. So citizens must start interrogating the leadership as far as the health priorities are concerned. If health becomes a priority for the voter, if health becomes a priority for the average citizen, it will become a priority for the politician, and it will become a priority for any government that is subsequently elected, because they will know, if I don't take care of the health of my people, then I'm going to be kicked out of office. And nobody enjoys being kicked out of office. But as long as it is not a priority for the voter, it's not a priority for the average citizen, it will not be a priority for any government. There are many other things that governments have to deal with and struggle with, and they will only focus on those that are a priority for the voter.
Dr. Ochanji, we've heard several times when the union has wanted to come out and say, look, if we don't have these requirements, or we don't have these standards at a very bare minimum kept, the only answer that we can have to this is issue a strike notice, which again, we've seen the same thing has been done now. Is this in a response to COVID, or is it in a response to the years of the lackluster approach that we've seen towards health and its requirements in this country? Kind of like what Professor Lukoye has been talking about.
Thank you. I join my senior Prof in identifying all the statements he has made. The strike is unfortunate, and it never comes at a point when we fully agree that we have to go on strike and we are happy about it. It's very unfortunate, but sometimes it's the only option that we are left with. We are not responding, we are not issuing the strike necessarily because of COVID, but because of perennial neglect that has climaxed in this pandemic. The fundamental things, as Prof has mentioned, that has been overlooked over a period of time. We know for sure that if you go on a strike, Kenyans will suffer. My mom is not spared, me as a person, not spared. But we must make some critical decisions and keep our leaders accountable if we have to enjoy health as a right. At the heart of it are medical workers, health workers who are completely at risk. We're working in a situation where our hospitals have more of become death traps and death rates. We cannot continue doing the same things and expect different results. We've talked about it's not the first time, and by the time we come up with a decision to go on strike, it's really a painful one. So yes, there are things to do with financing of health, infrastructure, human resource, commodity and supplies that have been neglected over a period of time.
Dr. I am certain that with the industrial action that you have planned, you anticipate certain results. But I want to go back into history a little bit. It isn't the first time, even long before the union was formed, doctors have aired their grievances by going on strike. Now, would you say that with this current strike that is being anticipated, that you will achieve something a great deal more than has been achieved in the past? And this thing that you hope to achieve, what is it exactly?
Our rallying call has always been very, very clear and involves around 5 things or 4 things when it comes to healthcare workers. Recruit, protect, compensate, motivate. Those are things that can be done immediately and revert the strike. When you're talking about recruitment, we have more than 1,000 locally trained doctors who are ready to be deployed to work. We haven't seen them being employed. It's very unfortunate that we have qualified doctors who can work, and there's the need for them to work, but we can't just put them in place of work because of misplaced priority. When you're talking about protection, and Prof has mentioned, we're talking about adequate and quality PPEs. It's very unfortunate that we have our frontline healthcare workers going to work without being protected. How do you expect someone to work without an N95 mask, without a gown, without a shoe cover, without headgear? These are things that can be done. And when you're talking about PPEs, it's not a one event in time. It needs adequate and proper planning so that it's constantly supplied. We see a case where it's supplied today, you're not able to show about it tomorrow. COVID is here, it's been with us for months, and it's going to be with us for another considerable period of time. So we must also look at things that are sustainable and is continuously affected. When we were talking about protection, we're having healthcare workers who do not even have medical cover. I mean, it's not strange. There's nothing we're asking new. NHIF exists right now. We pay premium because our medical allowances was withdrawn. We also pay 1,700 in terms of NHIF. That is something that, if it's collapsed together, is enough to provide comprehensive medical care for every worker. That's not something new. It's not a new demand. It's just that you need to enroll it. You need to roll it out to all the healthcare workers in this country. It's shameful that we are providing services that ourselves can't afford. And when you're talking about compensation, it must be looked at a point where, if you are giving this healthcare worker a compensation, look at it that you're also protecting yourself. If you fall sick, you will need that person to take care of you. And you also have them you also have to find a way of motivating them. It's sad that we're talking at a point where there's only 300 ICU beds in the whole country. Right now, as we are talking to you, all of them are full. God forbid, if you and I fall sick today, it will take a miracle to be admitted in any ICU because the 300 are full. We lost our colleague, a senior colleague, Dr. Ashraf. And it's because in Eldoret, the ICU bed is full. When you come to Naivasha, the ICU bed is full. When you come to Nakuru, the ICU bed is full. By the time the person gets in Nairobi, if you get a miracle to be admitted in Aga Khan or Nairobi also, it's just a miracle. But you're staring at death. So these are things that we believe the 21 days notice is a very long period of time. They can be done, they can be effected, and we can avert the strike. But more importantly, we must prioritize health and look at the perennial things that have disturbed us over a period of time.
Let's look at what those 21 days can achieve and whether it's actually possible to get extra ICU beds in those 21 days and what else could be done in the 21 days, or whether this strike notice is a fait accompli. The doctors will go on strike in 21 days. Prof, asante sana for joining us this morning. We hope to have another conversation with you in coming days.
Thank you very much for having me.
Thank you.
Asante sana.
Thank you, Prof.
Bye-bye.
This is a Situation Room, Kenya's biggest conversation. We have been speaking with Professor Lukoye Atwoli. He's the Dean at the Aga Khan University Medical College, East Africa. And also we have the Vice Chairperson of the Kenya Medical Practitioners, Pharmacists. Why do I keep saying pharmacists?
Don't worry.
Pharmacists.
Monday.
And Dentists Union, KMPDU, Dr. Allan Ochanji. Dr. Ochanji will be with us for a couple more minutes as we look at this particular issue of COVID-19, the response by the government, broadcasting on Spice FM, on KTN Home, and online, Spice FM KE, YouTube, Facebook, Twitter, spicefm.co.ke. On the line with us this morning is the Vice Chairperson of the KMPDU, the Kenya Medical Practitioners, Pharmacists, and Dentists Union, Dr. Allan Ochanji. It's suicidal, say the doctors as they give strike notice. This is the story on page 10 of the Standard this morning. Yesterday, the KMPDU issued this 21-day strike notice saying that they need the government to address the issues that are affecting healthcare workers in this period. Remember earlier, the doctors had actually made a resolution not to engage in any industrial action that will involve downing tools because of their role in the pandemic. But the situation, according to the Doctors' Union, has forced them to set aside the resolve. According to the Secretary General, Dr. Mwachonda Chibanzi, he said, doctors will not engage in a suicidal mission in the war against COVID-19. He termed the decision as painful but necessary because the doctors have relatives who are as well at risk of the virus. If these 3 weeks we are open for deliberations, but if the government starts the usual way of running to court, that will be the wrong direction, because if you take us back to work in the same environment, we will die. They're saying the political class and leadership have failed the healthcare workers and Kenyans at large, with the relevant reaction to the pandemic being just releasing daily updates. The doctors are saying the numbers making sense are these numbers making sense, or are we just counting the dead? The number of cases have increased with the rise in political activities, and in turn, hospitals are overwhelmed and doctors are forced to work in difficult environment. So as you were going to the break, Dr. Ochanji, you said these 21 days are enough for the government to start putting some things in order. And there was a 7-point demand that you issued yesterday with your strike notice. Among them, of course, is release the PPEs and others that are being held at KEMSA. supply them to the doctors across the country. But do you think the 21 days would be enough to get meaningful movement in terms of positive change from the government, Dr. Ochanji?
21 days is a very long time. In my view, we don't even need 2 days to do this thing if we put priority into all this stuff. Because we've provided a roadmap, we've given suggestions, not one, but so many times. If we are talking about a case where we already lost some doctors, we lost up to almost 6 doctors in 24 hours. If we're talking about, for the public, it might be statistics that we've lost 10 doctors. But for us, it's a person you work with, and you know for sure that having lost that person in that manner, you know that if at all, and God forbid, anything happens to you, the same will, you also will go in the same route. Mm-hmm. So we mean what we say that within 21 days, if the government is serious, it can be able to do all these things. I mean, how do you describe the fact that we've set up to 14 billion aside to do a referendum and done BDI in a case where we don't even have piped oxygen in our hospital? Mm. Why do we allocate such a huge amount of money if you cannot even provide a nurse with a PPE? I'll give an example of this. The governor there is the chair of health committee in the Council of Governors. Mm-hmm. They launched a building in the name of ICU about 4 months back. What happened 4 months later? We lost a nurse there because there was no ICU. In the eyes of the governor, what did he launch? He launched
the ICU.
But he launched a building. He failed to understand that ICU goes beyond the building. Mm. You need constant oxygen supply. You need someone trained to work there. You need commodities for that thing to function. You go into Moranga today, they also launched a building there. They launched a building in the name of ICU in a case where you don't even have anesthesiologists. These are the things that we must correct if we have to move forward as a nation. It's not magic, it's possible. We just need to reorient our thinking and put priority.
Okay, so what are the things that we're asking for? So let's look at these 21 days and say that certain things need to be put in place so that doctors don't go on strike, so that medical workers don't go on strike, right? And get the job done.
Yes.
What are we saying absolutely needs to be done now?
The minimum to avert the strike.
These are the things, right? We've talked about employment. We have more than 1,000 doctors who are trained. We need them to be deployed immediately. Mm-hmm. Because we're having overstrained workforce. Mm-hmm. There are those who've gone into isolation. We've lost others. Mm-hmm. We are strained. Mm-hmm. The 1,000 doctors can really come in handy and help care. Mm-hmm. The other thing, we need them to be protected. We need adequate and quality PPEs. Mm-hmm. We cannot do chances. You have PPE today. Mm-hmm. Tomorrow you don't have it. Mm-hmm. COVID has been with us. It's going to be with us for some few more months. Mm-hmm. We must put in mechanisms to ensure that every day, every healthcare worker has enough protective devices. Compensation. Mm-hmm. We've lost 10 colleagues. We've not even seen any form the government has done to compensate their families. If any healthcare worker dies today, you're on your own. We're talking about adequate insurance, NHIF comprehensive. Mm. It's shameful that you expect our doctors to work, but you cannot even provide them with a comprehensive medical cover if they were to get COVID in line of duty. Mm. That is bare minimum. We cannot work without adequate comprehensive medical cover. We are tired of contributing for our colleagues.
But how is this still a conversation, Dr. Ochanji? This, if I remember correctly, the president in one of his addresses during this COVID-19 period, he said that this is one of the things that is going to happen.
It was on July 6th, to be
We are
specific.
going to hire more doctors. Now you're talking about this is a demand that you're placing. We're going to hire 1,000 doctors. In fact, part of the money that was had initially been earmarked for UHC was to go to hiring doctors. Second, you are going to have higher allowances for medical professionals during this period. Third, you're going to have a comprehensive insurance cover. These are the demands that you're making in November, on the 16th of November. This conversation was had a long time ago. What happened?
So we are here and we need to do a scorecard. Tell me, COVID is here.
Yep.
Healthcare workers were given a flat rate allowance, which was at one point in time in the pay slip, and it was withdrawn.
Mm-hmm.
It was paid like for 2 months, and it was withdrawn, and it was not even given to any of them. COVID has been here for the better part of the year. We are going into the new year. We don't know what's going to happen. What is the logic of giving the allowance at one point in time?
Let's just be clear, Dr. Ochanji. You're saying that we know about the extra allowance that was to go to healthcare workers, from 20,000 shillings for doctors, going all the way down to, was it 5,000 shillings for the other cadres? Just going all the way down. Are you saying this was only paid twice?
It was paid once and it was withdrawn. It's no longer in the pay slip. Yet we continue working, continue treating patients faithfully, we continue working in those hospitals because we also have a duty.
Was there any
But
communication
the
on
government
this?
has never reciprocated well enough and shown goodwill.
Okay. And the issue of the comprehensive insurance cover.
Yes.
What happened with that?
You know, right now we have up to only 20 counties that offer a comprehensive NHIF insurance.
Mm-hmm.
You and I heard and saw NHIF CEO come out in public and say that you are on your own. NHIF will not cover COVID-related illnesses and death. Health workers included. So how do you wake up in the morning, faithfully go to work, knowing for sure that if I was to get COVID as I work, NHIF will not cover me? How? We only have 20 counties that offer comprehensive NHIF cover.
But
even in those
what
20...
what do you mean 20, Daktari? The president said that all healthcare workers during this COVID-19 period are going to get health insurance cover. Are you saying that this did not happen?
So that is the question, and that's the conversation we must candidly have. When the president said, among other things, that we need each county to have a 300 capacity bed, do we have those 300 capacity beds in each county?
Tell us, do we?
We don't. When the president said that each and every healthcare worker need a comprehensive medical cover, I'm here to tell you that we don't. We are not madmen to come and make noise in the public if I know for sure I'm covered. And we're saying this because we've lost colleagues and we've contributed money. So we don't have medical cover. When you are saying that we need healthcare workers recruited, it's a fact we have doctors who are trained in this country that are jobless. Yet we have a lot of gaps in our hospitals.
Dr. Ochanji, I have to ask this question.
There's pronouncement.
If I'm, forgive me for interrupting you, but does it mean that the pledge, because my colleague Eric asked this question, the pledge by the government through the president to employ doctors, were there no doctors employed?
That's the question you should ask. One, the CS, two, the PS, because if those doctors are employed, where were they employed? They must be taken to the hospitals where we work. We haven't seen that.
Okay, now there's a confusion here, and that's why we are keeping quiet, because this is it's a serious indictment on the part of the government. You, as the people who are on the ground, and you are trained doctors, and you represent doctors, you're saying that doctors were not employed during this period. The 1,000 healthcare workers that were going to be employed were not employed.
And were healthcare, I mean, let's talk about the healthcare fraternity.
Yeah.
Doctors,
nurses,
clinical officers, everyone who is in the health profession. Did the government employ more personnel or did it not?
We forget about even the pandemic. We have always talked about more employment and continuous. The burden has become worse during COVID. We haven't seen doctors, nurses, clinical officers, healthcare workers being employed. The worst thing is pronouncement was made so that this is done. That was not done. 2, we continue having gaps. And 3, we have a local pool where it's so easy just to come and pick them and then put them. They're already trained. They're ready to work. So the question you're asking me why healthcare workers haven't been employed should be put to the CSRs, should be put to the PS, Madam Ochanji, and to the relevant people. Why do they keep on neglecting healthcare workers? And it comes at a point when there's consideration that they want to go and import new doctors from Cuba. Who bewitched us?
That's an interesting discussion, but the reason why you see us harping on this same point is this. We are listening to you and we believe you, and we are thinking here collectively and wondering, we have doctors who are trained who are not employed.
Yes.
We have a crisis that requires all the doctors we can get our hands on.
Yes.
We have a situation we need all the healthcare fraternity that we have employed and trained in this country employed and engaged.
True.
And from what we are hearing is that there's no evidence to point to the fact that this has actually been done. But then there's a clincher to it. Health is a devolved function.
True.
Now, if it's a devolved function, much as we may take the hatchet to the Ministry of Health, do our counties have the capacity to employ more health workers?
One, health is a shared function. The national government also still has a role in terms of policy direction. 2, we have only one government and one country called Kenya. We don't have 47 countries. We only have one Kenya with 47 devolved units. All the money comes from the state. Counties, do they have capacity to hire? Yes, and absolutely, because we've seen them using money in other areas that are not priority. Why is it that when it comes to hiring healthcare workers, there's no money? But when it comes to buying big vehicles, building mansions, and doing other non-consequential things, there's money. So yes, there's absolutely enough money to employ all the healthcare workers. There's absolutely enough money to give them comprehensive medical coverage. It's just that we've never put it as a priority and we've never looked at it as a right.
Dr. Ochanji, this is not the first this is not the first strike notice that has been given by yourselves.
Yes.
Previously, even in this COVID period, there was another notice and there was intention to strike, several across the board. What is it that you're told then that stops the strike from taking place? And I ask this because it seems that when people are dying or when prominent people die, that is when some attention is given. And as morbid as it sounds, it seems that it is when thousands of people begin to drop off the face of the earth that somebody's going to sit up and pay attention or take notice. So what is it that you are told that makes you then recall the notice for strike on several occasions? If you have said that this is a perennial problem, obviously there's something that you're told that stops you then from going on strike on numerous occasions. But you're saying that certain things need to be done in order for you to operate. But somehow they seem to be able to tell you something that stops you then from going on strike.
I thank you. Going on strike is a very painful thing. And by the time we consider it, it's not something that we would want to do. So sometimes we just sit back and withdraw a strike notice. Not because anything has been done, but it's because you're considerate to the general public and to the masses.
Mm-hmm.
But it comes to a point in time where you cannot sit back and do that anymore. We are talking at a point where we have lost up to 10 colleagues, the people we know.
So with this strike notice, what guarantee do you have that these things that you're asking to be done within these 21 days will actually be done? Because it seems as if it's a button that you can press and then somebody's going to pay attention. But it's clear that doesn't guarantee any results. So with this one now, today, where we are.
By the time we are coming to this decision, take it from us that we will not go to work without properly being given medical cover. We will not go to work without PPEs.
But you know what's going to happen? And I've got to push this, because what is going to happen is that the 21
Because-
days will lapse, right? Somebody is going to come and say, all right, we're going to hire doctors. We're going to give you the health cover. And then the strike notice will be recalled. And then a month later, we're going to be having the same discussion yet again. What's to guarantee that that will not be the outcome again of this process?
If there was appropriate and adequate leadership in the ministry and also in the country, and one that prioritizes health, we don't even need to come and ask for a guarantee. We just need to fix things and ensure that things are working. Our bare minimum, as I've told you, is comprehensive medical cover. The other thing is PPEs. You can take it from us that so long as there are no PPEs, we will not go to work. Because if you go to work without PPE, you know what you're doing? You're simply presenting yourself to a death trap.
Sure.
So who would want to do that?
But doctor,
We've seen it, we've experienced it. We are not going to sit back and see ourselves exposed. You don't have a means of treating yourself. Salary is not paid on time. The same government that is withholding your salary cannot provide you with a medical cover and cannot guarantee your protection when it comes to the PPEs. So how do you expect this person to work? They will not go to work. After the 21 days, if the government doesn't do any other thing, we will sit back at home and join our family.
It is a tricky balance. Indeed, it is, because it's like you're in a war and you're the one who has the likelihood of being shot first, and yet you're not being given the ammunition and the equipment you require. It is true, and it's a tricky balance. And it's even trickier when you consider that if you go on strike, you will then now put other people who don't have your training and your capacity to understand in the front line. And they are likely to be shot because they are larger in numbers. So they are likely to be even harder hit by your absence. How do you as a union balance this? Must people die in order for this to be achieved?
Seems so.
Must doctors die in order for us to be given PPEs? No. Must Kenyans die? Must Kenyans die when we go on strike? No. Can these things be avoided? Yes. But this is how we've done, and we've balanced it. For you to give strike, you only need 7 days. We have given 21 days. That is a very long time to do this thing. 2, we've withdrawn strike notices so many times before because we give this benefit that perhaps the government might have a goodwill to implement this thing. A time comes when you cannot sit back and wait for a goodwill from the government. While even if you keep quiet, you still have death. Kenyans still suffer without proper medication. We have hospitals that are dry of oxygen. So why should we sit and clap and cheer on a hospital that is becoming a horror, an empty space, and a point where people, instead of coming to get treated, they come to die? We cannot.
In this period, Dr. as we wind up the conversation, in this COVID-19 period, has your union been engaging the government on these matters that you're raising? Because there are those that will just look at your reaction now and feel it's also a very emotive and emotional reaction because of the loss of your colleagues. So this is also very emotional. You're very raw right now. You've lost your colleagues and therefore you're taking action. But prior to this, have you been engaging the government?
We have engaged the government so many times. We have written letters that have been met with neglect. We went for a nationwide strike, unfortunately, in 2017. The things we are talking about right now were captured in a document called a CP. The government is yet to fully implement that document. If that document was implemented, I can assure you, Eric, we will not go on strike. Because that document covers things to do with recruitment, employment, compensation, protection. I mean, it's not a miracle that we're talking about unpreparedness at this point. It is that we were not prepared from the word go. COVID, yes, unfortunately as it is, there are also other things. We have highly resistant TB. We also have Ebola. a system that works must be prepared. You cannot be reactionary every day. But a point comes when now you have to push the government to act.
Is this the straw that's going to break the camel's back? Are we done at this point saying unless we have these solutions, we're not going back to work?
Unless we're sure that when you go to hospital, you're given the things to work, we are not going back to work. Unless you're sure if you go to hospital, the government will take care of your bills, we are not going back to work. I like the narrative you mentioned, that being at the forefront, we're the first to receive the bullet. That is true. But you also look at it at the context where you have a gun, you have something to protect you, you have a shield. So yes, there are chances you might die because no one really controls death. But you must also be protected even as you go into that war. So long as you are not protected, so long as you are exposed, we will not go ahead and expose ourselves further. And this is to the best interest of Kenyans, because right now, we are having counties that do not employ. If you get injured in Mandera, you will not get a maxillofacial surgeon. If you get a problem in Homa Bay, you'll be rushed to Nairobi. We've had Kenyans dying in between, in transition, being transferred from Kisii to Nairobi for something that can be fixed in Kisii.
Yep.
It's time that perhaps also as Kenyans, we just need to hold our leaders accountable. You don't need to travel from Lamu to come to Nairobi to get treated. You need a doctor there. And the government must ensure that they retain you there, they compensate you so that you offer your services to the Mwananchi.
Good point,
It's a
mate.
time that Kenyans should also have a national conversation about health.
Thank you very much. Dr. Allan Ochanji is the Vice Chairperson of the KMPDU, that's the Kenya Medical Practitioners, Pharmacists and Dentists Union. Thank you very much for talking to us, raising the issues that they have raised on the 21-day strike notice to doctors.
This is the Situation Room, the only way to start your day.